Good evening, everyone. It's been a long day, plenty of webinars going on at the same time. So I'd like to welcome you to the fifth wave of complex PCI ECAs. This wave is focusing on acute coronary syndromes and PCI in complex scenarios within the acute coronary syndrome context. Now, I have to start by welcoming my co-chairman of the series, Dr. Flavio Rebecchini from Verona. I think Omar Göktekin hasn't joined yet, but Omar is the other co-chairman. And this series, we're happy and honored to have Dr. Magdi Abdelhamid join us to moderate the session, and Dr. Mohammed Usama, who should be showing up very shortly. We also have two presentations from Dr. Ahmed Sayed from Ain Shams University, Dr. Muhammad Sadaqa from Alexandria University, but that will be preceded by a talk on complex scenarios and acute coronary syndromes by Dr. Flavio. Flavio, the floor is yours. Flavio, unmute yourself, please.
Thank you. Yeah, thank you very much. It's a pleasure to share this couple of hours with you from Verona, Italy, with my colleagues and friends from Egypt. And well, when we organized this session of today with Ahmed, he asked me to focus on some of the points that are key in the management of acute coronary syndrome patients. So I will go through three examples of what will be developed later by Dr. Magdi and Dr. Nabil in the examples they will develop later. So I will start sharing my presentation. Is that okay? Do you see it?
Yeah.
Yeah?
Yes.
You confirm you see?
Yeah.
Yeah.
Okay.
Yeah.
Okay, so there it goes. On our opinion, the key issues we could discuss today relates to this kind of arguments. One is the patient with high bleeding risk and the way to treat them and the new recommendations from the European guidelines regarding the antithrombotic therapy. Another challenging scenario is that of patients having calcified lesions requiring specific devices to deal with the stenosis. Third is the use of intravascular imaging, which is advised in the setting of calcified coronary lesions. But there might be a subset of patients, which might be small, but it's very important, of patients with impaired LV function, in which the protection with circulatory devices might be advised. And then, of course, I would say the most common situation is that of the management of the non-culprit lesions in patients presenting with STEMI or non-STEMI. So have you heard everything is okay? The sound, the images, shall I go on? Ahmed?
Yes.
Yeah, go ahead. Yeah.
Yes,
Okay.
Flavio, we can hear.
I'm getting paranoid with this issue of talking alone in front of a screen, you know. Sometimes it may happen that you remain by your own, speaking like a madman, so I want to be sure that you are there. So
yeah, I was muted, sorry for that.
Okay, the first case, it's about a high bleeding risk patient. This is a common situation in older patients. This is a 75 years old guy who recently had an oncologic surgery because of a pancreatic cancer. The surgeon said he has a good prognosis after adjuvant chemotherapy. His previous story is mute. He had just a benign prostatic hyperplasia operated. In the past, he has an episode of bleeding because of gastritis, and he has a moderate kidney function. For the first time after surgery, he had ST depression with chest pain. As you can see, it's a diffuse ST depression, and he was put on medical therapy. After medical therapy with beta blockers and nitrates and aspirin, he did well, actually had no residual symptoms, but in any case, considering the risk of the patient, he preferred to undergo coronary angiogram, reminding you that he is old, he has an active cancer, he has a previous bleeding event, and some renal impairment. His X-ray was normal as well as the ACG with the right bundle band block at with no signs of ischemia at rest, and a normal LV function. Okay, so after discussion, because the patient could have remained in medical therapy, he preferred to undergo angiography. And of course, this is what you find when you make a coronary angiogram in a 75 years old male with the risk factors. The right coronary artery is totally occluded. The left main has a significant stenosis at the bifurcation and is a heavily calcified left main bifurcation. So the patient was discussed in the heart team because we supposed that surgery was the best indication for the patient. But because of the previous oncologic history, the surgeons thought that the eventual benefits at long term of surgery were not in good balance with his oncologic story. So actually the surgeons refer the patients for coronary percutaneous revascularization. This is performed by the radial access, which is our default strategy. And of course, even more in high bleeding risk patients. And we will start, and this is a strong recommendation or advice at least, we will start with an inspection of the intravascular aspect of this diffuse calcification from the left main to the LAD. Why is that? Because of course we confirm that there is a lot of calcium, but this is exactly what we wanted to investigate, which was the origin of the circumflex. The origin of the circumflex looks at the IVUS totally clean, okay? And this is the reason why we planned our strategy. You can see here the ostium of the circ with no plaque, and then the critical and calcified stenosis of the proximal LAD. So this decided us to undergo with the aggressive rotational atherectomy, but limited to the LAD. And no protection of a wire during rotational atherectomy on the circ. And this is the image after rotational atherectomy that confirms that the ostium of the circ is clean. So we can follow, as you can see in the lower right image, the ostium of the circ is completely free. So this confirms our strategy of following a provisional stenting strategy. You can see the points of fracture of the rotational plus balloon treatment of the proximal LAD with a 180 degrees calcification of the LAD, and then the rest is quite simple. It's a provisional stenting with an onyx from the left main to the LAD, followed by the pod and the kissing for this final angiographic image. Of course, after that, you have the IVUS on the table. It's strongly recommended that you check your final result with the IVUS. And this is what you find. You find that there is a clear under expansion in the smaller picture. You see the non-apposition of the stent to the left main wall. So what we did was a further dilatation with a 6.0 millimeters balloon up to obtaining, as you can see, pre and post a much better, because the proximal part of the left main shaft was very big. In the end, this is the angiographic result, which looks good. And the final summary of the IVUS, which shows the good new carina with no involvement of the proximal circ, the good expansion of the proximal LAD. And of course, there is distal disease on the circumflex and in diagonal, but these are minor branches that we don't want to stent, because being a high bleeding risk patient with an active cancer, we wanted to minimize the number of stents and the amount of metal. So as you can see, the patient was discharged 3 days later with a dual antiplatelet therapy for only 1 month, and giving you this message. I mean, simple stenting, ideally provisional, is the recommended strategy in high bleeding risk patients. The usefulness of intravascular imaging, like in this case, was very informative to the site the stenting technique and to rely on a provisional stenting with only one. The vessel preparation, which is key for having a good long-term result. And in this case, we decided to use rotational atherectomy. And then, thanks to the availability of the new drug-eluting stents, in particular the Biofreedom and the Onyx stent, dual antiplatelet therapy can be safely withdrawn after 1 month, because this is a high bleeding risk patient. So the treatment we did was only 1 week of dual antiplatelet therapy, and then 1 month of dual antiplatelet therapy, and then he remained on NOAC and alone. So if you want, we can discuss this case, Ahmed, or we go through the other 2 cases I have prepared and we leave the discussion for an end. I will do this in obviously less than an hour.
I prefer to discuss this case first before going to the next case, if you like, Ahmed.
Sure, Dr. Magdi, while everything is fresh.
Thank you very much,
For
Dr.
participants,
Flavio.
please do send us your questions on the chat box. Go ahead, Dr. Magdi, sorry.
Thank you very much, Dr. Flavio. This is a very interesting, challenging case. Elderly patient, malignancy, high bleeding risk, renal dysfunction, complex anatomy. My first question, which bleeding risk score in such patients are using? Crusade bleeding risk score or Park bleeding risk score? And technically, why you didn't start with the right coronary artery as a backup before going to the left main? Is it important to do PCI for the right coronary artery before starting the left main, and how we can identify the culprit lesion in a non-STEMI patient, such case?
Okay, thank you for these questions. I mean, we used a Hasbled score, and the patient had a 4 points, which is a high bleeding risk. And then regarding the selection, I mean, you have seen that when the patient had chest pain at rest, he had diffuse ST depression in all the anterior leads. So we assume that the problem was the left main. And this is why we afforded the left main. And why not touching the right? Well, the right was not a dominant vessel. You saw that the circumflex was quite an extent vessel. And actually, you know, this patient is 75. And he has a cancer. So in the best of the perspective, he might live 2, 3, 5 years, okay? I absolutely think that you might die before if you have a severe stenosis of the left main. I don't think that you will live longer if you open an occluded coronary or right coronary artery. So opening the right would give higher risk of having thrombosis because you put stents, or having bleedings because you put stents, but will not change your lifetime prognosis. And then you treat the left main. Then you may be a perfectionist and want to do a perfect 2-stent strategy on the left main, but it's again, you have high bleeding risk, high thrombotic risk. So what you need to obtain, it's a good revascularization with the least amount of metal and the shortest dual antiplatelet therapy. That was our thought.
Excellent points. Any questions from the panel or the audience before Flavio moves to the second part?
The contrast-induced nephropathy in this elderly man with the low GFR at baseline. The tips and tricks to avoid contrast nephropathy.
Very nice point. Thank you for that. I am really obsessed with the contrast. So in a procedure like that, we use less than 50 or 60 milliliters of contrast media, because doing IVUS is very helpful. You decide from the beginning the length of your stent. You decide you will not do a dual stenting. If you have seen, there were 2 images before and 2 images later, 1 after rotablator, and that's all what you need. So using IVUS, it's very helpful. You can check for dissections. You can of course, decide on the expansion of the stent without doing angiograms. And this is the way I try to minimize the amount of contrast.
It is an excellent question, Flavio, and we've been an excellent answer, and we've been sort of stressing the value of intravascular ultrasound in complex anatomies and perhaps complex scenarios such as that, because if there is one thing that would give you sort of reassurance that you can get away with a 1 month of dual antiplatelets, despite the available literature, it is perhaps being absolutely sure that from an anatomical perspective, you have a perfectly well expanded and well opposed stent with a minimal stent area that is quite sufficient. So,
Yeah.
and you've also got the added value of understanding the degree of calcification, the osteomal circumflex, which obviously allowed you to get away with the one stent strategy, and the added value of reducing contrast. But I just want to draw everyone's attention and remind the audience that contrast-induced nephropathy is not just about contrast. So all the steps that Flavio took to make this a smooth and safe procedure with minimal hemodynamic derangement is absolutely important for acute kidney injury as well. So it's not just the contrast, it's the degree, the volume overload, it's the hemodynamic compromise and periods of hypotension during the procedure that also are extremely important. So again, intravascular ultrasound can give you all those advantages.
Yes, and if you allow me another concept, I mean, there are some, especially young colleagues are keen on OCT. OCT is much more beautiful to see than IVUS. But on my opinion, the major drawback of OCT is that you have to give a lot of contrast. Each time you do an OCT run, it's about 20 cc of contrast. So when you have done 3, it's all the contrast you need to do the PCI. And of course, in the left main, it's even more difficult because you will have I'd say it's more difficult to get a good injection and a good support. So in these cases, I absolutely do prefer IVUS, which is contrast-less imaging.
Absolutely. So Flavio, I think you can move to the second part.
Okay, I tell you something. We started our experience with Impella many years ago. I implanted my first Impella in 2007. So what to say? We have a large experience. We started as usual with a lot of enthusiasm, and it takes years until you understand when you really need it. So I will show this case and then we will discuss because the indication to Impella can be argued, but it's a good example on how to think on a procedure of a protected PCI. Do you see the slide? Yes?
No, we've lost them.
Okay, so I have to share again.
Share again.
That
Omar.
Hello,
Omar,
hi.
Hi, Omar.
Sorry for being late. I was in the cat lab. I'm Flavio.
Sure. Hello, Omar.
Hi.
Great to see you, Omar.
Yeah.
And we have Dr. Mohammed Salim as well joining us.
Thank you, Ahmed.
Hello.
I'm sorry, I'm a little bit late. Welcome, everybody. Thank you.
Great to have you, Omar.
Hi, Dr. Mohammed. Hi, Dr. Omar. How are you?
Hi,
Dr. Magdi.
Hi, Magdi.
Okay. Hi, Dr. Omar.
We see your slides now, Flavio.
Okay. So this is quite an unusual case, and I will tell you, 77 years old, hypertensive. This patient had bypass graft in 2006. And it's a very strange operation. He has a saphenous vein to the right, and this is normal. And then he had a vein to the oblique marginal of the circ. And you will see that the mammary artery was implanted with a wire connection on the vein. And why is that? Because probably during the intervention, the surgeons have problem with the mammary and it was damaged. And so instead of throwing it away and putting 3 veins, they did an anastomosis in between the vein to the circ and the LAD. Good ejection fraction and a mild renal dysfunction. He came with some strange symptoms. You see hypertension and shortness of breath, but with an important increment in troponin since the beginning. We put the patient on the intensive care unit for observation. And soon after, couple of hours later, he had this ACG. And again, of course, a diffuse ST depression in the anterior leads and ST elevation in AVR. And the echo showed an akinesia on the lateral and the apical wall. And you can see the echo after admission. During the first day of the admission, 38% and a mild mitral regurgitation. So because of this ACG, of course, we did the angiogram. These are the native vessels. The right coronary artery, native, is partially open with a lot of calcium. This is the vein graph to the right that goes to the PDA only, and it is patent and well functioning, so no problems with the right. And this is the left coronary. You see this massive amount of calcium on the left main. The LAD is occluded as the circ. And this is the bypass. It's a large vein that goes to the oblique marginal. And you see that the mammary artery is connected to the vein. And exactly at the point of the anastomosis, there is a stenosis. The stenosis is at the same point where the anastomosis of the artery. So conservative therapy, of course, he did well after we started medical therapy. We asked the surgeon if they wanted to redo CABG, but they said the mammary artery was already done. The veins were no longer available. So the option was in between medical therapy and PCI. In case of PCI, you have this old vein from 2006, which is a degenerated vein, very large. I don't know if you have seen it. I will show it again. It's very calcified lesion, and it's at the point of the anastomosis. So, of course, doing this PCI was a left main equivalent because you had the vein going to the circ and the mammary going to the LAD in a degenerated and calcified vein. So this is why we decided to go for a protected PCI. This is an image from the radial to see that the distal circulation with the iliacs was good. So no problem for implanting the impella. You know that this requires first a multipurpose catheter in the left ventricle. You put a 0.18 supportive wire. The 0.18 serves as a guidance to navigate with the impella in the aortic arch, and then the impella is in place. You know that it makes a suction of blood in the left ventricle and injection of blood in the ascending aorta. Okay, so with the impella on board, we did the angiogram, and this is done again from the right radial with a 6-French guiding catheter. And there you see the lesion. It's very calcified vein. You know that the veins are high risk of rupture in case you use high pressure. And so what we did to start was, again, putting a wire on the distal part of the vein, and then doing an IVUS assessment to understand how much calcium, which distribution, and how tight the stenosis was. You can see the calcium of the vein. This is distal to the stenosis. And again, another important question was whether this is the plaque. You see how rich of soft plaque. The MLA is very small here. And then the question is, how involved is the ostium of the mammary? And here you have the answer. This is the mammary coming in between times 12 and 3. And you see that it's perfectly clean. This is good news because the ostium of the mammary is not involved. The plaque is limited to the vein. Okay, so this provides a good information, again, to try a simpler strategy with provisional only. And so this is what we did. In any case, we put a wire for safety in the mammary. So this is the wire in the mammary artery. And we do an IVUS assessment on the mammary. And we will have the confirmation of what I said before. The mammary has no atherosclerosis, and the point of junction in the anastomosis with the vein is clean. You see it there. Okay, so our strategy is done. This will be an attempt for provisional stenting, but we have a lot of calcium. So we decided to go directly with a shock wave. Shock wave is a very easy to use device because it's like a balloon. You see that the stenosis was soft, so we managed to cross directly with the shock wave, and we gave 4 complete cycles with the shock wave balloon with a good expansion at 4 millimeters. After that, just for, let's say, curiosity purpose, we did another IVUS to see which is the effect of the shock wave on the calcified plaque. Actually, you see the dilatation. You don't see, there you see in the detail, you will see a detail of these 2 points of fracture of the circumferential calcification. Hope you can see it. In the lower right at time 3, in the upper right at time 3 and time 11. Okay? Mm-hmm. So next will be the stent. And this goes very easily. It's a Onyx 518 expanded at 16 atmospheres with good expansion, a check afterwards, and again, the IVUS to check for the expansion of the stent. Here you have it on the vein. This is the origin of the mammary artery, and this is the proximal part. Next is the IVUS on the mammary after we change the wires. But you see here the mammary artery, which is clean. And you go to the here, exactly here, the jump to the vein, which is totally clean. So the procedure is done. The patient was hemodynamically stable during the full procedure. This is the final angiographic assessment. You see the mammary artery totally clean going to the LAD. And given the good hemodynamic conditions, we remove the impella at the end of the procedure and close the vascular access with 2 pre-implanted proglides. And the patient was discharged after a couple of days with dual antiplatelet therapy advised for 12 months. And that's it.
Again, a very interesting case, Flavio. Flavio, do you mind showing us sorry, can you go back to the presentation and show us the native left system? I'm sorry for that.
Yes.
There's one question I have to you and to Omar is whether you'd consider going for the native left system, especially with a mechanical support, support in place. My second question to you while we look at it is, what was the pulsatility like during the procedure? Were there any moments where the impella was doing much of the job?
Well, yes, during the inflation of the shock wave and the stenting, we had hypotension, but was very well tolerated. I don't know, the patient had 40% ejection fraction, so it's not so bad. Okay, it's not so bad. But of course, Ahmed, the real worries was about the possibility of having either a dissection on the left main, an occlusion, sorry, on the mammary, an occlusion on the flow on the mammary, or a very important no reflow on the vein. This was not related to the procedure. What you have seen has been quite easy and simple, but about the risk of unpredictable low flow or low flow on the mammary. This is
I think this is one of the important things with mechanical support is while there are some useful algorithms to guide you, this is a very sort of peculiar anatomy, and we do know it's either the very bad anatomy, be it a single remaining vessel, or very peculiar anatomy where a very large area of myocardium can be placed at jeopardy during the procedure, or a patient with pre-existing poor ventricular function and comorbidity. So I think on this occasion, you had plenty of reasons to believe that things can go south. And I'm looking at the native circulation, it's really bad. I think it's, while we do prefer native vessel revascularization, on this occasion, this would have been a horrendous procedure. And I would have gone for the saphenous. Omar, what about you?
Yes, Bilal, it's great case. If I wouldn't have impella in my lab for this patient, so, you know, I still go to lesion rather than native vessel, because as you see, LAD is very calcified, you know, long lesion. But I see that there is a competition in the circuit. So I would go with the both access, you know, with left system and saphan graft. If something happens, I can easily reach to circ and OM, I think, because when I do double injection, I could see the anatomy better, because if we have any no reflow, we have to have, you know, B plan if you don't have impella. So I would do a double, you know, access here, left system and graft. And I don't think that the risk for no reflow in Lima that much. You know, I would just wire the Lima first, and then after stanting, if I might have no reflow in the saphan graft, yes, but I don't think I could have it in for Lima. I don't think so. But of course, you can't be sure for 100%. So if anything happens to saphan graft, I could go just native circ to do dilatation and, you know, to have heart. Then I could recross the. I try to recross the Lima to do kissing. It's a very good case, you know. Of course, it's more risky than to do left main, you know, because we could have lots of issue here. In left main, it's more predictable for us. But we have nice flow here, nice competition.
It's an excellent outcome. Yes,
Yeah,
Dr. Magdi,
may I
please
have?
go ahead.
Okay.
Dr. Flavio, thank you very much. An excellent case. Going back again to the indication of impella and such case in the absence of cardiogenic shock. So the indication here is to minimize the risk in a high risk PCI. Do we have a predictors for complications of impella, bleeding, stroke, TIA, limb ischemia, etc., etc.? And what about the indications for 2B3 receptor antagonist with a ring graft PCI?
Okay, thank you for the question. I think that this image shows you, answers one of your questions. Most of the complications related to impella are related to the vascular access, because these are patients with acute coronary syndromes, dual antiplatelet therapy, high doses of heparin. And if you have bad arteries, you may have limb ischemia or bleeding complications. So I always do a shot on the iliacs, and I decide which is the best vascular access. Okay, I always pre-implant 2 proglides. So in the best of the situations that you can remove it immediately, you send the patient with no problems. And in case you have to leave it for a couple of days, you are ready to remove the impella and obtain good hemostasis without the risk of bleeding. As to the opinion on how can you predict if you need it or not, this is very difficult. I tell you, I always implant an impella when I work with the patient with very, very severe LV function, which is not this case, but especially when the patient is hypotensive. I hate doing complex procedures at high ischemic risk when the patient has 95 millimeters of mercury of pressure, because you have practically no margin of safety. I mean, anything that happens, you have to intubate the patient and give adrenaline. So if you put a patient on the table and he's 140 systolic, probably you don't need it. If you put the patient on the table and he's 95 systolic, probably you will need it. This is the most practical advice I can give you. In this case, I accept that it was a little bit of an excess of care. I agree with that. But remember that veins are nasty. You never know when you will get low flow, no reflow. This is a calcified vein. It may break. You can have perforation. The anastomosis of the lima was exactly at the point of the plaque. I will show you that it was a soft plaque with a lot of material and burden. Maybe you put a balloon and you have total occlusion because of low flow of the circ and the LAD, and the patient crashes. And then you need the impeller. It didn't happen. I am happy it didn't happen. But if it would have, I was ready to manage the situation without getting the patient in danger and myself getting too nervous.
Yes.
Excellent
can I
answer,
have,
Dr. Mohammed.
okay, excellent work, Dr. Flavio. Really, it's outstanding. I want to ask you about your experience in intravascular lithotripsy in the degenerated venous grafts, which are calcified. What's your experience here?
Yes, thank you for this question. This is my first experience in a vein.
Really? Yeah,
Yes,
okay.
in a saphenous vein. And you know, I called the people from Shockwave, asking them if this was on or off label. And they told me that it is totally off label.
Off label.
I mean, the Shockwave is not approved for using in veins. And they sent me a case report by Margaret McEntergaard, you know, the lady from she works in Scotland.
The British CTO group,
Glasgow. Yeah, and she had published a series of 3 cases. So there is very little experience, but I think it's a great indication because you know that veins are nasty and they may perforate more easily than native vessels. And when you have a perforation in a vein, you have to put a cover stent. But in this case, cover stent was not an option because if you put a cover stent, you occlude the mammary.
Of
so
course.
that this is why I was so, I'd say, prudent in doing this case, which was technically very simple, but potentially very risky.
I think, Flavio, it's very wise of you when you say that veins can behave in very unpredictable ways. And exactly, you don't have enough time to behave. I totally love the comment about hating hypotension. It's exactly what we all dread when you get a patient on the table with a blood pressure of 90 or 95, and you're up against a complex procedure. You know this is a very bad sign. Tachycardia is a bad sign. A narrow pulse pressure is a bad sign. But one thing, it's difficult, especially with impellers being so bloody expensive. We frequently resort to ECMOs, although they don't provide you with the same afterload reduction or reduction in myocardial oxygen demand, but they give you some reliable sorts for tissue perfusion during complex procedures. But again, they're expensive and the setup is even more demanding in terms of large bore arterial and venous access. But the things that make it sort of more safe is what Flavio does. Always do a check injection first, understand the iliofemoral anatomy. An ultrasound guided puncture helps dramatically with large bore access. And what we tend to do is whenever we think about mechanical support and we're still in the gray zone, we get it ready in the room. We have our perfusionist in the room and we stick in a right heart cath. So we do a right heart cath, measure the wedge pressure at baseline and continue to monitor it throughout the procedure. And if we get rising wedge pressure as we go along, so we start at 12, 15, if it's going 18 and 20, we know that this is time we want to get our mechanical support up and running. Perhaps in this case, you probably wouldn't have had time if distal embolization had happened. So I think I would have done the same, in all honesty.
Good. Yeah, I'm not telling that you need to implant impeller. We are talking of high risk procedures in acute coronary syndromes. And I wanted to write awareness about the risk of having hemodynamic crash in some situations. So think about LV support, whatever you have. Even a balloon pump might help in some cases, or ECMO if you have it and you know how to use. And that was just one of the points of my talk today.
Thank you,
It's a
Fabio.
very good point.
Omar.
Yes, I'd like to make a comment. If we do complex PCI, low ejection fraction, if we have, great risk for hemodynamic instability, I think we have to do two things. The first, intra-aortic balloon pump should be in the angiola. So if we need it, we have to use it immediately. And secondly, if you do complex PCI, any complex PCI, it's better to have norepinephrine or noradrenaline, in pump infusion set, for urgent use. If we have severe hypertension, norepinephrine is definitely help us, to give us some moment to insert stent or do some ballooning. If you do norepinephrine bolus, shortly patient might have acute pulmonary edema. So in that case, it's very important to do, only infusion, norepinephrine or noradrenaline. I think it's very important to have them in the lab ready to go. That's very important to me.
So Fabio, one question from the audience before you carry on is about distal embolization protection devices with SVG interventions. I mean, it's a very old and debatable topic, but I would love to hear your thoughts on that.
It's a good point. When I saw the case, when I planned the case, I said I would put an epi filter distally on the vein. There is only one randomized trial done at the beginning of the 2000 that demonstrated that putting the percusurge, actually this occlusion and aspiration device, offered advantage in terms of reduction of the CK amount of the CK movement with no clinical impact. Yes. So I think in this vein, it could have been a good idea. Yes, I agree with that. I agree with that.
But in terms of the lesion, Flavio, it seems not that thrombotic lesion to me. I think it's also, shows me it's a soft plaque. I wouldn't that much worried about filter in this case.
This is why I didn't put the filter. But the point was well taken by the colleague, yes.
Okay, Flavio, we're ready for your third case. Shoot.
Okay, this is the last issue. I think it's very interesting for us to discuss is what to do with the bystanding lesions. This is a case we did 1 year ago when Verona and the north of Italy was at the peak of the pandemic. So we were in big troubles, but we never stopped. And I'm very proud to say that this is the only hospital in this region, Veneto, 8 million people, which is nothing compared to El Cairo, but for our Italy region, it's very populated. It's the only cardiology division that never stopped performing emergency procedures. And I am very proud of that. This patient, it's a young male with a typical chest pain with a very short pre-hospital delay. Transferred, of course, through the emergency room. He underwent the COVID-19 protocol. You see there are minor ST changes in the inferior leads and the lateral leads. You see V6, and so the suspicious was an ST elevation lateral, but you see this large right with a significant lesion and many lesions on the left. Probably, not probably, the culprit lesion was considered to be this oblique marginal because you see these images, which is a clear intravascular thrombus. You see it here. But there is also a lesion on this first marginal or intermediate, whatever you say. It's a tight lesion. And then we see a lesion on the proximal LAD, a lesion on the origin of the diagonal, and this is the culprit second marginal of the circ. So this is the result after the stenting and the ballooning of the culprit lesion. The patient had ST resolution and symptoms resolution, but we still have all these lesions. This is the ACG and the echo. And he went to the intensive care unit until we got the negative swabs. And we knew that he was not a COVID patient. The clinical course was uneventful with a minimum CK-MB rise. You see the ACG after 2 days was quite normal. But of course, at this point, what to do with all these lesions? And I tell you what we do in Verona. We are very keen on coronary physiology, as you might know. So we put the patient on the table again 3 days later to assess the importance of this right coronary artery, which is a dominant one. And the physiology has no room for doubts. FFR is largely negative, it's 0.91, and is coherent with the IFR, which is practically 1. So we decided not to touch the right, and then we move to the left system. We investigated before the intermediate branch, and you can see again, the two results are concordant. FFR is 85 and the IFR is 90. So we didn't touch this branch. And then we went to the most important vessel, which is the LAD. And here you have borderline results. It's 78 on the LAD, which is positive if you consider 80, it's negative if you consider 75, and it's borderline for the IFR. So very likely this lesion might be positive. As it was COVID time, we had to make the shortest hospital stay, and the patient was stable, and so we discharged the patient on day 4. But we did schedule a control after 6 months. And this is the repeated cath after 6 months. I put it here, the measurements performed in November, 6 months later, which shows totally normal physiologic values despite the 50 to 60% right. And this is the measurement we obtained in April during the acute coronary syndrome. So you see that there is practically no difference, saying that in the non-culprit lesion, the physiologic measurements in this artery was reliable, and we did a proper deferral on the non-culprit. This is the other non-culprit, the intermediate, which was again negative FFR and IFR, which is very similar to what we measured during the acute coronary syndrome. But the most important was the LAD. And when we repeated the LAD measurement, we saw that there was a further impairment compared to baseline from 78 to 74, and the IFR from 89 to 85. Being a young patient and being a proximal LAD, of course, we did the PCI. So in conclusion, we think that the clearly negative values are reliable, even in of non-culprit lesions are reliable, as the clearly positive. The problem stays on the borderline values in vessels with important supply to large myocardial territories. In these cases, probably you might either revascularize at the first time, because actually was positive, FFR was 0.78, or you repeat the measurement to make sure that you don't leave a large ischemic territory. This is supported by the studies, but I have seen briefly that my colleagues that will present cases will discuss on the trial. So I will skip the trials. And as the final case, I will show you something which I think is very important. This is a patient we enrolled in Verona in the FLARE trial that was published in the New England. It's a young male, 54, with acute coronary syndrome presentation because of the subocclusion of the proximal LAD. Okay? He got a stent on the proximal LAD with good result. And then he underwent the physiologic assessment of this diffuse disease of the right coronary artery and this nasty ostial disease of the intermediate and proximal circ branch. And guess what? Look at this. Looks awful, and it's very unfavorable to do PCI. It will be a difficult PCI. This is the wire on the intermediate. This is the wire on the circ. And guess what? These are totally normal values, despite the angiographic image. So, of course, I was happy not to be obliged to perform this PCI. And then I moved to the right. And I think that anyone would say that this is a critical stenosis on the right, but the patient had been randomized to IFR, so we could not perform FFR. So we have to rely on the non-hyperemic index. And again, was not borderline, was clearly negative. So we discharged the patient. But per protocol, he underwent 1 year follow-up with stress test, which was maximal and negative. After nearly 2 years, he underwent a stress test with echo, dobutamine, and was negative. And he underwent another control, clinical and echo, and was normal. The patient was okay for 4 years and a half. And in October 2018, he has chest pain at rest. So we repeated coronary angiogram. At that point, you say, you see, we should have treated the right coronary artery, but the right coronary artery was absolutely unchanged. And the new finding was a subocclusion of the distal LAD. You see that the proximal circ and the intermediate remains unchanged. You see the stent in the proximal LAD, no restenosis, and there is a subocclusion of the distal LAD with low flow in the distal part. It's a small vessel, so he underwent balloon PCI of this lesion. And this is the final result. Since then, other 2 years of follow-up, and he is doing well. So 7 years from the randomization in the FLARE trial. To tell you how reliable it might be doing this physiologic examination during the acute coronary syndrome. I think it's an amazing case because you have these 7 years follow-up of the right and the circ and the intermediate remaining stable, while unexpectedly the distal LAD had atherosclerotic progression, becoming symptomatic after 4 years and a half. That's all.
Flavio, thank you so much. I think the whole presentation is amazing. And you hammered 2 points extremely valuable about the use of intravascular imaging and the value of physiology. This patient would have been in much more trouble had you probably tried to fix his right, which would have taken 2 to 3 stents and a very lousy or critical part in the ramus, probably protruding all the way to the left main. I mean, we always stress the value for complete revascularization, but complete revascularization means that essentially for physiologically significant lesions, and this is unfortunately one of the other areas besides intravascular imaging that are heavily underutilized where we practice. Dr. Magdi, any comments or questions from your end?
No, thank you, Ahmed. It's an amazing presentation by Dr. Flavio. Thank you, Dr. Flavio.
Thank you.
Dr. Mohammed Salim.
Thank you so much, Ahmed. I don't have any questions, but I think we have to rewrite again the angiographic assessment of the severity of the lesions based on the QCA, as there is a marked discrepancy between the severity and the physiological assessment. This is my only comment.
I'm sure Flavio can tell you loads and loads about that.
Yeah, you're absolutely right. And you know, the more you do physiology, the more you get surprised. We have, but also the contrary happens. It's less frequent, but it also happens that you have a 30% proximal stenosis on the LAD, and you say, "Oh, come on, this is," and then you measure, and it's positive, and then you have improvement on LV function in these patients. So it's true. I mean, when I started teaching medicine at the university nearly 20 years ago, and all what we were saying was about the percentage of stenosis, 3-vessel disease, and surgery, and blah, 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 blah. And now my lessons are totally different. We don't spoke about percentage of stenosis anymore. We talk about coronary flow reserve and FFR, and myocardial viability, and syntax score to say whether you should be operated or treated by PCI, which is a totally different story.
Yes, absolutely right. Yes.
Omar, any final thoughts before we move to Ahmed Saeed's case? Unmute yourself, please, Omar.
Yes, a very good cases, Flavio, again. I think it's really important to do physiological assessments, you know, at least it's not 95% or more, I think, but you show us, you know, in 7 years, lesions stay almost the same, very important. But the thing is, we do physiological assessment for PCI, but most of the time, you know, if after angiogram, when we discuss the surgeons, if there's possibility for a CABG operation, they don't care about physiology, and just they say, okay, that's good case, we do operation. So I think we also should do some physiological assessment for patients who are candidate for CABG operation. What do you think?
Well, this was the question addressed by the Syntax 2 registry. Unfortunately, was not a randomized trial, was a comparison of the Syntax results with a cohort of patients that were treated with physiology guided, and IVUS guided multi-vessel disease. And after 2 years, there is no difference in terms of mortality, infarction, and target vessel revascularization. So we should do a randomized trial comparing angiographically guided bypass surgery and physiologically guided PCI. And this will give the answer that we all need. But of course, one is the old-fashioned medicine, very effective. If you put a mammary artery on an LAD, the patient will become immortal. We know that, that's true. But we might obtain similar results with minimally invasive, really minimal, which doesn't mean 7 stents, but mean what is really needed. And then relying on physiology is not only physiology, my friends, it's physiology and medical therapy, because we are taking care seriously of blood pressure. We didn't care about blood pressure 20 years ago. We are taking seriously the lipid levels, the metabolic control of glycides. We are taking care of the style of living, exercise, and everything makes our procedures less invasive and more effective. But of course, this is a missing piece of information that we still don't have.
Last comment,
yes,
Dr. Ahmed, please. Just only 1 second. Dr. Flavio, it's not only the physiological lesion assessment and severity, it's also the vulnerability of the plaque, the vulnerable plaques, which liable to rupture and induce acute coronary syndrome. So we might have 80% stenosis in an unculprit vessel and stable plaque. It just needs medical treatment, high dose statins and medical treatment like seen in ischemia trial. There is no concern, no need for PCI. What do you think regarding this?
Yeah, I absolutely agree. I absolutely agree. Yes, you're right. The point is that it's difficult to identify these vulnerable plaques. Okay, the culprit lesion you identify, but the others you don't know. I mean, maybe physiologically negative, but you don't know if they are vulnerable. All the story written behind the virtual histology was interesting, but was never validated. And I tell you something, Volcano is taking out the virtual histology package from all their devices because people don't use it. And so there is a little bit of, this is not coherent, but it's true. I think that if we could identify this vulnerable plaque, we would do much more revascularization therapy.
Omar, to answer your question, I think our surgeons here are not infrequently would send us patients back and saying, guys, this looks like a 60% lesion on the OM. Please do an FFR rather than we put a graft and it closes 2-3 months down the line. So I think what Flavio is saying, it is a mindset that is changing indeed. And it's also applies to be it surgical revascularization or obviously PCI. So there is a definite change of mindset in the past few years. So thank you, Flavio, for amazing case presentations and an overall presentation and key points. I'm forever grateful to you.
My pleasure.
It's my pleasure to introduce Ahmed Said, a colleague and a dear friend. Ahmed is from Ain Shams University, one of the pioneers of structural interventions, essentially on the aortic side. And we're sort of dragging him away from his arena today, or his loved arena, into coronaries on multi-vessel complex scenarios, but again, with a focus on culprit versus complete revascularization. This obviously attains to which lesions to address and when to address them.
Okay, thanks, Ahmed, and thanks. Let me, before going through my presentation, congratulate Flavio for the very nice cases and the very nice approach. Unfortunately, functional assessment, which is a very important tool of assessment of multi-vessel disease patients who present with an ACS, is not frequently used in every cath lab here in Egypt because of problems with reimbursements from the insurance companies. My topic is about STEMI patients who present with multi-vessel disease and when to tackle the non-infarct related arteries. So, should we go for the culprit only or go for complete revascularization? I'll go for two cases which have a lot of things in common. The first case is a 55 years old male patient who presented last week with an infraposterior STEMI at 4 in the morning. He had a pain to door time of 30 minutes. He was only smoker, no other known risk factors. The pre-admission CT, which is a routine step before admitting the patient in the COVID era, showed that he's suspected to have COVID with a CORADS 3. Unfortunately, the patient arrested just after doing the CT, and there was a continuous CPR for 40 minutes, so he received more than 10 DC shots. The cath lab was unfortunately occupied, so we had to transfer the patient to a nearby hospital for primary PCI. The patient was intubated with significantly impaired Glasgow scale, yet he was hemodynamically stable after getting back from from his cardiac arrest. You can see his ECG is a significant inferior leads ST elevation with significant depression in the anteroceptor leads. This was his coronary angiography from the radial axis, and you see he has a significant proximal LAD bifurcating with a diagonal branch. His LCX is totally occluded. The caudal view, and this was his right coronary artery. So this is an interactive session. So let me ask you what to do. Should we go for culprit only, complete revascularization? And if you are going to go for complete revascularization, are you going to do a bifurcation stenting for the LAD and diagonal, or you are going to go for provisional stenting for the LAD? Regarding the LCX intervention, are you with thrombus aspiration, yes or no?
A lot of questions, Omar.
Can I see the angio once more, please? Okay, so I don't see well LAD diagonal lesion, from this angiogram. But if I were the operator, I just cross this circle lesion and I would do small ballooning there, like 2 balloon, and to see what I have. If I have good amount of thrombus, yes, I could do thrombectomy. If I don't have that much thrombus, just I stunted it. For the diagonal, I need to see other wider, other position.
This is, can I add something?
Yes, Dr. Magdi, please.
This is an anteroposterolateral infarction, anteroposterolateral, consistent with circumflex occlusion, not RCA from the start. So I will open the CX, the culprit lesion, causing the cardiac arrest and the anteroposterolateral STEMI. And then regarding the LAD during the index of hospitalization, I will not touch the LAD in the same session. I will only do reperfusion through PCI for the CX, and then PCI for LAD in another session during the index of hospitalization, which is a class 2A recommendation in the guidelines.
I also wouldn't, yes, Magdi, I also wouldn't do LAD diagonal in the same session, but I like to make sure that the lesion, because in here I don't have any idea.
The diagonal looks not critically stenosis. It looks diseased, but not so severe. So maybe a provisional stenting will be the strategy of bifurcation LAD diagonal in such case. So let us see what Ahmed is.
Flavio, I'm sure you have something to add. A pressure wire, perhaps.
No, very briefly, I go directly to open the circ. With or without aspiration, I think makes not a big difference. And then I will wait until the patient recovers, extubate to see which is the neurological state, the LV function, eventual mitral regurgitation, because this inferolateral postural might damage the posterior papillar muscle and have important MR, and everything should be taken into consideration before dealing with the LAD, but not in the acute infarction. I agree with that.
Okay.
Excellent.
That's excellent feedback. So I went with the thrombus aspiration, and this was the LCX at the thrombus aspiration. And I went for stenting of the LAD with a 3.0 onyx stent. And that was the final outcome. The patient was hemodynamically stable. ECG, that segment resolved. He was transferred to the CCU because of being suspected COVID and because of we've preferred to do a stage procedure. The patient was extubated the next day, fully conscious, no neurological deficit. His echo showed an ejection fraction of 45% with segmental motion. in the infra and posterior walls, no significant valvular lesions, and his PCR was negative. So discharge the patient or doing the LED before discharge. I think we all agree that the LED should be fixed before discharging the patient. So again, the patient was brought to the cath lab 2 days ago, and assessment of the LED and diagonal. At the very beginning, and from the previous images, I was planning from the very beginning to go for a two-stand technique with a VK crush, but after reassessing the LED and diagonal branches, I thought that the ostium of the diagonal branch, as Dr. Magdi said, was fine. So I decided to go for a provisionless stenting, and both the LED and the diagonal branches were wired. And again, stenting of the LED provisionally. Doing POT, and then final assessment. I think the diagonal branch was fine. The patient was asymptomatic, and we decided to stop at that stage. Any feedback before going to the second case?
Excellent case, Dr. Ahmed, well managed. This is a good strategy for management. You save the patient in the acute setting, and then you did the LED in another session as a staged procedure, which is good and accepted strategy. Thank you very much.
I just have one question to the panel. So we agree that the staging the procedure is probably right. We do, the data supports complete over incomplete revascularization, but do we really have the data that supports that this has to be done within the index hospitalization? I mean, it's from logistic purposes and cost purposes, it probably makes a lot of sense. We've resorted to a slightly different strategy during the COVID era because we want to get ACS patients quickly out of hospital. So we're actually bringing them back for the second procedure. But again, this is more logistic rather than from an evidence perspective. So Omar and Flavio, any thoughts on, does it really make a difference when, in terms of outcomes, do you complete your revascularization?
In my hospital, I wouldn't do in the same hospitalization in this patient. We would call him back, and I'm not sure if the lesion is severe, so we might work on it also.
Okay, Flavio.
Well, yes, I think that taking a decision before discharge is wise, and is what is recommended by the PRAMI and the multi and all the studies. It's better to do it, let's say, not in the acute phase, but before discharge. My question would have been in my team whether this LED was physiologically positive. So I would have done the same you did, but I would have put a pressure wire on the LED because I am not convinced that it was positive. But if you don't have the pressure wire, I do believe that having a good new generation stent is better than having a stable atherosclerotic plaque in this big LED, because I mean, we are not working with Cypher and Taxus anymore. You are implanting Onyx, and this is a different story.
Flavio, just for the sake of argument, so how do you take the data from complete, where complete revascularization anytime within the first 45 days was collectively better than incomplete revascularization?
Well, yeah, it depends on what you revascularize. I mean, it depends
Good
on
point.
this trial didn't provide information on myocardial viability. And I don't remember if all the revascularizations were done in the same procedure or before.
They were a mixture. They were a mixture. No, they were all, it was comparing a mixture of delayed revascularization, be it during the same index hospitalization or within the first 45 days, versus not completely revascularizing the patient. But none had it during the acute phase. So this is why I'm familiar with data from PAMI and so forth, but I totally agree about the wisdom in making up your mind. It's just that the COVID era is sort of forcing us all to take unusual measures to some extent. And one of them that we've been doing is trying to minimize hospital stay as much as possible. But,
and I think Ahmed, individualized approach is recommended. You treat not every patient the same management. You have, according to the age, comorbidities, according to the amount myocardium supplied by the non-culprit vessel, a lot of considerations should be taken before decision making for such cases.
Yeah, totally agree. Ahmed, we're back with you. Sorry for that.
So this is a very interesting discussion, actually. So the second case was a 46 years old female patient, very quite uncommon. She was diabetic, dyslipidemic, and again presented with infraposterior STEMI. Pain to door time was 60 minutes, and she was presenting at 3 in the afternoon. Her ECG showed again inferior ST elevation with acid depression in the anteroseptal leads and tall R in the V2. Again, she had a very close anatomy to the first case. The LCX was totally occluded. She had 2 successive lesions in the LAD. 2 eccentric plaques would be seen in next views, especially in the lateral view, and the right coronary showed a significant mid-segment lesion. So again, the question is, should we go for a culprit-only revascularization, or should we tackle the non-infarct-related arches in this young lady presenting with infraposterior STEMI?
I think we have a consensus on that. Yeah.
Excuse me?
I think we have a consensus on that.
So you vote for culprit only?
The culprit only, yeah.
Okay. So this lady, I decided to treat her a bit differently. Opening the LCX first. It was a very rapid and easy procedure. Direct PCI, then stenting, and a very good flow in the LCX. This view, in the lateral view, you can see the eccentric significant LAD lesions. So I decided to go for complete revascularization this time. Stenting of the proximal LAD.
I'm sure you'll be telling us why you changed strategy this time round.
Because the issue.
And then the, excuse me?
Sometimes I have to finish the procedure too. Yeah.
So I thought that all the lesions are very focal and straightforward lesions, and the patient is very stable with a very little amount of contrast. And instead of bringing her back to the cath lab, I thought, why not to go for complete revascularization? And the debate is whether going for complete revascularization or staging is still debatable. We all agree that complete revascularization should be considered in patients with STEMI and multivessel disease from the data from the PRAMI, compare acute and the Dynamic-3, whether with function assessment or not. However, the optimum time of complete revascularization in hemodynamically stable patients is still a matter of debate. All recent randomized clinical trials failed to show differences in the hard clinical endpoints and we still need more data whether to stage or stay in patients with STEMI and multivessel disease. So far, non-infarct related lesion revascularization and intervention strategy in STEMI patients with multivessel disease, whether upfront, stage, or delayed, depends on the wise operator judgment. And as Dr. Magdi said, it should be based on individual approach according to the patient you are dealing with, whether he's stable, whether the other lesions are straightforward or not. I think that's why I decided to show both cases, and I'm really interested to hear your feedback.
I think your first case was you had doubts about whether the LED would end with a bifurcation with a diagonal, which would almost certainly entail a longer procedure.
Maybe because the patient as well wasn't, you weren't confident about the patient, the clinical outcome of the patient as well, because he was, yes.
It was the peri-arrest and intubation and everything. Yeah. So yes. I think it's very reasonable to tailor therapy as you did and as Dr. Magdi suggested in different scenarios. I think the way I address those patients, COVID aside, is I think about how to make sure that we tackle the appropriate lesions. So once you're comfortably sorted out the culprit lesion, addressing other lesions, ideally guided by physiology, and we take it from there, taking multiple factors into account: the hemodynamic stability, the amount of contrast, the amount of radiation, the expected complexity of the non-culprit lesion, and there are logistic factors that govern us frequently, I have to admit, although not particularly from an evidence perspective. Now, Flavio, I think any thoughts on that?
No, I absolutely agree with your comments. If I might add one concept, is how more easily we afford this issue of putting more stents in patients we don't know, because we don't know the clinical history. And now that we can safely interrupt dual antiplatelet therapy after 1 month, because now this lady has a long stent on the LAD and on the circ and on the right. Let's suppose that she starts bleeding and you have to interrupt dual antiplatelet therapy. 1 year ago, it would have been a nightmare and you have been guilty, and probably you wouldn't have implanted all these stents. Now that you have 2 stents which are known to be safe, of course, we go more easily. I mean, our sense of being guilty of something bad for the patient, it's much smaller, and we can treat these non-culprit lesions with more, I'd say, confidence. I think it's in my mind, it has changed a lot, my reasoning, as it was 1 year ago.
As it's an excellent point. In the heat of the moment and a STEMI, you hardly ever take the appropriate clinical history and know everything about the patient to plan the right therapy for him or her. So that's an excellent point. And in all honesty, at 4 a.m. in the morning, when everyone in the cath lab on the whole is drained, there is an element of concentration as well. But these are excellent points. Any points from Dr. Magdi and Dr. Omar before we move to Dr. Salah?
Thank you very much, Dr. Ahmed. Excellent cases. Well done. Congratulations. I don't have any questions.
Omar?
Yeah, I agree with you guys. I think Flavio made a very important point. But still, as you said, during the acute intervention, all lesions deserve the perfect stent implantation, with pre-dilatation and stent implantation, and also post-dilatation. It takes sometimes time, patient might have calcified lesion. So in terms of concentration, also I like to do its next session rather than the same index procedure.
There's one question from Dr. Amr Fanawani. In your practice for shocked patients, would you prefer to proceed for total revascularization if you're covered by Impella? Now, this is in the context of shock, where we do have data on this occasion, but it's a very peculiar question. If you've put an Impella in, and you now have the mechanical support to pull you off, and obviously you don't want to be putting it in again. Flavio, with the person with the most experience in Impellas.
Well, you know, you should put Impella before you start doing PCIs, because running after the hemodynamic crash is very frustrating. You have to prevent the hemodynamic crash. So if your hemodynamic is unstable and your PCI is very complex and very demanding, you should put the LV protection before. Once you have put it, and we are talking specifically of Impella, is such an expensive device that then you have to take the chance of doing everything in one shot. So you try to do complete revasc, even total occlusions, okay? Because you will not put the patient on Impella twice. So this is my experience.
Excellent practical point. Thank you, Flavio. Now, the last case presentation is going to be Dr. Mohammed Sadaqa from Alexandria University. Thank you, Dr. Mohammed, for joining us today. And again, addressing one peculiar aspect of acute coronary syndrome patients, and that's high bleeding risk. Dr. Sadaqa.
Actually, hello, everybody. I really enjoyed the meeting from the beginning, of course. And I would like to thank Dr. Gendi, Dr. Omar, and Dr. Flavio for asking me to join this important teaching course. I really enjoyed. And of course, also, I enjoyed the wisdom of management of cases by Dr. Flavio. I really enjoyed. Now I'm going to adding some patient with high bleeding risk. I hope it will complete the portfolio after the important two cases presented by my colleague, Dr. Ahmed. My patient is female patient, 76 years old. Actually, she is hypertensive diabetic dyslipidemic patient conducting sedentary life with some depression. She had a past medical history of severe osteoarthritis on wheelchair. She had an untreated recent cancer breast because of her severe frailty. She had an old DVT, thrombosed arteriovenous shunt. She's on chronic renal failure on hemodialysis through implanted catheter. She had a chronic anemia by hemoglobin 8.7 gram per deciliter. This lady is presented with acute coronary syndrome, non-STEMI with acute pulmonary edema. Her blood pressure was 170/90, tachycardic, ECG showing ST segment depression, 3 mm in anterior leads. Her echo showed preserved ejection fraction with no regionality, mild aortic stenosis, and some regurgitation in mitral and tricuspid valve. This is the basal coronary angiogram. So as you can see here, she had a calcified coronary artery disease with diffuse distal RCA lesions and critical proximal LAD with bifurcation with D1. And also we have distal diffuse LCX disease. So by calculation of her Euroscore, it was very high. And also the syntax score also is very high, and syntax score 2, of course, in favor of CABG. But after heart team consultation, because this patient had an elderly patient and all criteria are not in favor of CABG, we do recommend to do PCI for the culprit vessel only because of the severe comorbidities with this frail elderly patient with restricted mobility and condition which may affect the rehabilitation process. So my decision at that time to do incomplete revascularization, to do PCI culprit vessel only, and in my mind that was the proximal LAD. So I decided to do PCI for the LAD with one drug stent, leaving the distal RCA and distal LCX and diagonal for medical treatment, trying to minimize the procedure as much as I can and try to minimize the number of stents inserted in such high bleeding risk patient, elderly patient. Of course, using of risk score as a guidance for duration of dual antiplatelet therapy is very important. This is class 2B recommendation. And when you calculate precise DAPT score for such lady, the score, of course, more than 25. So we decided to use short depth duration for such a lady. And as you can see here, the precise depth, the cluster is very high, and the calculated score for major bleeding or minor bleeding was more than 4.14%, and 12 months risk of TIMI major bleeding was more than 2%. As you can see here, this is the last European guidelines for management of non-STEMI, putting the academic research criterion for deciding the risk of bleeding by two major criteria, one major, sorry, or two minor criteria. And we calculated that she's an elderly patient, she had a renal failure, she had an anemia, and her hemoglobin less than 11 gram. She had hospitalization for bleeding during the last year from hematuria and menorrhagia, and had recent cancer, non-treated like cancer breast. So by Crusade score for post-MI bleeding, her point is 82, and the risk of in-hospital major bleeding is almost 30%. So it's a very high bleeding risk patient. And guided by the last European guidelines for management of non-STEMI, the patient criteria, clinical comorbidities, you have to balance between ischemic risk and bleeding risk. And based on that, we decided that an acute coronary syndrome, putting drug-eluting stent with short duration, like the Onyx stent. Of course, we are encouraged now to put such kind of stent in this high bleeding risk, replacing the old BioFreedom one. And the duration of that should be the shortest the better. So as simple as that, I put a guide wire, trying to simplify things, doing direct stenting by Onyx, 3.534 millimeter. Then post dilatation with non-compliant balloon. And this is the final result, which was accepted to me at that point, leaving this patient to conduct her life smoothly with less complication as much as I can. And of course, the patient discharged home safely after 3 days without in-hospital MACE, with residual syntax score almost 21 because of this diagonal and distal RCA and distal LCX. Unfortunately, after 9 months, this patient developed hematemesis with hemoglobin 4.5 gram, and she needed blood transfusion. 2 months later, patient developed crescendo angina with non-STEMI at the end. And here, this is ECG showing, as you can see here, extreme ST segment depression in the anterior leads with raising in the AVR. So at that point, I suspected that patient had an eccentric stenosis or distal left main lesion. As you can see here, after 11 months, she developed this critical distal left main lesion progression, which is astonishing to me. And her LV function was perfect at that time. So now the bleeding risk become more and more higher after these attacks of bleeding. So I decided to put another Onyx in the left main, trying to make it simple as much as I can. 2 wires, one in the left main and wire in the LCX. Onyx 4.18, trying to optimize the position of the stent. Then post dilatation, and this is the final result. So patient discharged home safely after 4 days without in-hospital MACE, DAPT only for 1 month, then single antiplatelet only clopidogrel for 3 months, and after 8 months, patient still asymptomatic without MACE, and her risk of bleeding at that time is okay. And this is one of our patients published in this important study, the outcome of different pattern percutaneous revascularization for non-STEMI with multivessel disease. We published this group of patients, which was a cluster of more than 400 patients, with non-STEMI, comparing complete revascularization versus incomplete revascularization. And we concluded that complete revascularization, of course, is very important, either doing that in the same hospital stay or staged after patient discharged and come back again. And calculation of residual syntax score is very important to judge the residual non-treated lesion. And my take-home message: high bleeding risk patients are large, growing, and complex population. They are presented up to 40% of patients at high bleeding risk. Limited evidence of those patients because usually they are excluded from stent and drug trials, and they are complex patients. They have all usually complex anatomy, and they have 3% greater risk of bleeding event for high bleeding extended dual antiplatelet regimen, and they have 4% greater risk of mortality associated with post-discharge bleeding. Until this moment, the optimal strategy to balance between bleeding and ischemic risk for high bleeding risk is still not known. And I'd like to thank you all for your good listening.
Thank you, Dr. Sada. Again, just shows the complexity of those patients, and it's sort of is an ongoing problem. You just don't get away from it within the first few months. On the one hand, especially in the context of an ACS, we know this is an inflammatory, procoagulable state. With that risk increasing or remaining high for the first year, and perhaps beyond the first year. On the other hand, the risk of bleeding is also something they never seem to get away from, except in very specific circumstances where they have reversible factors. And by virtue of age alone, it tends to get worse as well. So it's an ever ongoing dilemma. We are lucky that we have some evidence now to support very short use, 1 month use of dual antiplatelets with 2 stent platforms, one of them being a very good workhorse drug-eluting stent to some extent. But nevertheless, you've shown an excellent example that there is no simple solution to it. Dr. Magdi.
I have a question. Thank you very much, Dr. Sada. Excellent case as usual, excellent presentation, very challenging case. Before my question, I have to mention, I have to stress that patients with malignancy should not be deprived of intervention and PCI, because the mortality in those patients is cardiovascular mortality, not the mortality of due to cancer. So we have seen the first case by Dr. Flavio, patient with cancer prostate, and now we have patients with cancer. And in both cases, those patients were subjected to PCI. So we have to treat those patients as we are treating our regular patients in the daily practice. Regarding my question, Dr. Sada, in such patients with very high bleeding risk, how to monitor those patients in the daily practice, how to see your patient to minimize the risk for bleeding? PPI should be considered, the hemoglobin every 1 month, the risk for blood transfusion if we need blood transfusion, especially after when she developed hematemesis, how to handle the DAP therapy in such a critical patient.
Actually, Dr. Magdi, I would like to thank you for this important question, because after finishing the procedure, this is not the end of the story. I think a close observation of such important high bleeding risk patient is much more important than the procedure itself. So as you mentioned, first of all, you have to give the patient family a very strong instruction as regarding the factor principle of precipitating the risk of bleeding. One, this patient should be monitored during her rehabilitation period by walking, trying not to fall down. 2, avoid non-steroidal anti-inflammatory as much as you can. 3, try to keep her hemoglobin around 10 grams, not less than that. 4, avoid as much as you can strong instruments. Some patient trying to cut her nails, trying to do some sharp procedures. 5, try to keep the dual antiplatelet as shortest as possible. As I did in such patient, I did it for just 1 month dual antiplatelet. Then after that, 3 months is only clopidogrel. Then you can stop safely based on this data. And sometimes you can give the aspirin only for 1 week, and then you go for clopidogrel only. Try to keep her blood pressure always lower than 150 over 90, because sometimes they have intracranial hemorrhage, as you all know. All of these factors are very important to keep your patient away from risk of bleeding. And finally, you have nothing else to do.
So, Omar, any thoughts on this particular patient and the topic in general?
Yes, I think it's important to choose right stent. You know, if you deal with the high bleeding patient, this is very important. And I like that Mohammed did a provisional stent in the LAD you know, he didn't treat diagonal, then if you think that he treated diagonal in that case, so he might have to do clots or you know, double kiss crash technique. Then dual antiplatelet therapy could be more important in that patient. So if we have high risk patient, we have to keep, you know, as simple as we could. I think.
Flavio, final words of wisdom.
Oh, no, this is not my role. I enjoyed Mohammed cases very much because I like his styling of making things simple, which is the best thing for these complex patients. So patients, the more fragile they are, the less aggressive you should be. This is a teaching point. And of course, another food for thought that we should share is how many times you see a patient coming with a stent thrombosis and how many times you see a patient coming with a bleeding.
Yeah,
I think that the relationship is 10-1. And he showed it. I mean, the lady didn't come with the thrombosis on the LAD. She came with 4 points of hemoglobin. So, and this is the reality. High bleeding risk patients are, of course, also high thrombotic risk, but the drugs are terrible. I mean, drugs are necessary because we implant the stents, but are very high risk, potentially very high risk drugs. So we have to be very careful doing the less as possible. And I enjoyed very much his cases and all this global discussion on complex patients, because I mean, we don't need to discuss on young people with normal LV function and treating angina. I think we have to, these procedures are life-saving and sometimes are life-killing if you do too much. I think there was a lot of wisdom in this panel and in this discussion, and this is why I enjoyed it very much.
Thank you very much, Flavio. Dr. Magdi.
Thank you very much, Dr. Ahmed. It was a pleasure to join this distinguished group, speakers, panelists, excellent discussion, interesting cases. Thank you very much for involving me in this excellent webinar.
Thank you, Dr. Magdi. Thank you, Ahmed. Thank you, Dr. Muhammad. Flavio and Omar, thank you for a wonderful session today. Flavio, thank you for an amazing talk, and thank you for putting this program together, Omar and Flavio. And I just want to invite everyone to join us in our last wave. This is going to be focusing on calcified lesions, yet another frontier of CHIP patients, if you may call it. It's going to be on the 15th at 8 p.m. Cairo time. That will be Ramadan, but I hope that every one of you can join us. I enjoyed today massively. The presentations, the cases, the discussions were extremely educational and informative, and they did have a lot of practical take-home messages and a lot of wisdom indeed. Thank you, everyone, and look forward.
Thank you very much. See you. Bye-bye.
Bye-bye.
Bye-bye.